Hi, I'm Dr. Virginia Quiney. I am a Wessex Cancer Alliance GP, and I'm going to talk to Richard. I'll hand over to you. Introduce yourself.
I'm Dr. Richard Roope. I've been a GP in the area for over 30 years. I'm currently the Hampshire and Isle of Wight primary care cancer lead, and also I'm one of the GPs working at the Rapid Investigation Service.
Brilliant. Well, thanks for talking to me today, Richard. And you're the perfect person to ask about the RIS and really how we can get the most out of it as GPs. I thought we might start by talking about what is the RIS and who is it most appropriate for?
Okay, so in 2018, the long-term plan was introduced and there was a section on cancer within that. And one of the commitments was that every area should have access to a rapid diagnostic service. And in our patch, that developed originally as a RDC, Rapid Diagnostic Centre, but following patient feedback, it was changed to have the name of the Rapid Investigation Service because in quite a lot of patients, we don't actually reach a diagnosis.
Okay. And so, but it isn't just to investigate symptoms, we're looking more for cancer.
Absolutely. So it is essentially a non-site specific cancer referral pathway. So it's for patients where there is no clear area or speciality to refer to, but you still have that concern that there may be a cancer somewhere. So the really common presentations are unexplained weight loss, raised platelet count for no good reason, and general sort of lethargy, tiredness, those sort of symptoms that have been persistent and, if anything, progressing.
Okay, so if I, as a GP, want to refer into the RIS, there's quite a lot of paperwork to complete. There's a form, it asks for an examination. Can you tell me the importance of doing all of those things?
Yeah, so I think it's helpful to know how the service works. So it does cover the whole of Wessex, and it's a completely remote service. So the vast majority of patient engagements will be by phone. There is the option for video phone, but very few use it. And so we rely on having the clinician's examination findings. So the referring clinician is essentially our hands, our ears, our stethoscope. So they will fill in the gaps that we can't access because they're not in the room with us. And it's really important the filter tests are essentially there to confirm that it is a non-site specific pathway. So for instance, the filter test will include a fit test. And if the fit comes back as over 10, then it has now become a site-specific condition and then needs to be referred straight through to the colorectal team, because actually coming to us may add a couple of weeks to their referral pathway timeline.
Okay, so that answers one question as to why I need to order so many tests. And from what you've said, I need to wait for those results to come back and look at them before referring to the RIS.
Yeah, so particularly the other one that is really important is the renal function, because most patients will end up having a chest abdo-pelvis CT scan with contrast, and they need to have reasonable renal function. So we need a recent creatinine and EGFR, certainly within 3 months of them seeing us.
Okay, and I've come across some of my GP colleagues saying that they are getting some referrals rejected. In your experience, why might that be happening?
Tends to be either because it's an incomplete referral or it's actually an inappropriate referral. And that may be on the basis that their risk of cancer is so tiny. And I think some GPs are understandably seeing it as a rapid investigation service and they want their patient rapidly investigated. But actually the chance of their symptom bundle with their age and demographics, etc., the chances of it being a cancer is very small. We will very often use a scoring system called the Q Cancer Score. And if it is really very small, we would not investigate with a view to it being a cancer. And there may be a more appropriate referral pathway for that patient.
Okay. And do you might reject a referral if it is incomplete in terms of what's sent into?
So if the bits that are incomplete basically mean that we're not going to be able to investigate, so what we will sometimes do is say if there is just one missing blood test, so there might be an out-of-date EGFR that hasn't been sufficiently isn't sufficiently close to the referral, we would still see the patient, but we would ask that test to be done as what we call a background test. But where it is a test that might actually enable a more appropriate and more rapid investigation by the appropriate specialist, that's when we would be saying, no, they need to be going through a different pathway.
Okay, so it's really about getting the important tests done that might change the outcomes to where the patient needs to be. Those things need to be done.
Yeah, and then there are other more general tests, say for instance thyroid function and the HbA1c. They may actually in themselves account for the symptoms that the patient has. So if they're very tired and a lot of lethargy, a lot of fatigue, and the thyroid function test hasn't been done, and actually they're then shown to be hypothyroid, then clearly they don't need to be coming for a cancer review. They need to be either being treated or seeing an endocrinologist.
Okay. And I've also heard a lot of GPs say, well, there's again a lot of information that needs to be put on the form, a lot of things that need to be done, and the filter tests. Wouldn't it just be simpler if we could refer and directly access CT?
Yeah, this is a really interesting one. It is a question that I've heard a lot, but I think it's, if you look at the time that it takes for a patient to come through our service, we've actually done a time and motion study, and it takes about 3 hours per patient from beginning to end. So that's checking the referral, then having the consultation with the patient, arranging the investigations, then fielding the investigation results, the report, and then dealing either with the onward referral to a cancer specialist or a non-cancer specialist if we found a non-cancer significant condition, or actually, as we get in a lot of them, a lot of incidental findings which then need to be managed and discussed within the MDT.
Okay, so actually you're dealing with quite a lot of work and on the back of the tests that you do, that you're kind of taking away and dealing with yourselves.
Absolutely. And if you were doing that chest abdo-pelvis CT scan yourself, you're then taking on that responsibility for the interpretation of the report and then the onward management of the patient. Okay.
And what common cancers are you finding that are diagnosed through the RIS?
So probably the big three are surprisingly lung is really quite common, renal and the hematological cancers. Those are probably the big three, but we've had a full range of cancers right across the board. So I think we're up to 24 different types of cancer that we found in the time that we've been working.
Do you have a feel as to what proportion of referrals that come through the RIS end up with a cancer diagnosis?
So it's between 4 and 5%.
Okay.
So on the basis that NG12 suggests that patients should be referred if their risk of having cancer goes over the 3% threshold, it would appear that the patients coming to us are appropriate, and the patients that we're accepting are within that category. But probably as of equal significance, another 10% of the referrals have a significant non-cancer diagnosis, which we're then able to access prompt treatment for, and we would make that referral directly and just let the GP know that that referral has been made.
And what kind of conditions are you seeing that are non-cancer?
Huge range. We had one, the report came through saying multi-splenic infarcts, and the patient actually had infective endocarditis, and we were able to phone the patient immediately and get them admitted to cardiology. Quite a few pulmonary emboli, which again we're acting on immediately, so we're able to access that very quickly, but a very broad range from thyroid enlargement, benign thyroid enlargements, right through to some skin conditions. So really quite interesting range of problems.
And is there anything that you would like GPs to know about the RIS that we haven't already talked about?
The value of a good referral is amazing, and we have some really cracking referrals where all the information is there. The filter tests are all done. Sadly, there's some that are less cracking, and I think one of the problems is that when you click the box saying see below and you think that the information is being drawn across to the referral documentation, in quite a lot of cases it isn't, and all we have is unexplained weight loss, see below, and that's all the information that we have. So quite variable in the quality. The majority are really good though.
So from your perspective, what you want us to be doing is completing our filter tests, examining our patients, and filling in the referral form, particularly that bit that explains to you why we're concerned about the
Yeah.
patient.
The most important and most helpful box is the free text box as to why you feel that the patient may have cancer and what's giving you concern, because we know that clinician intuition is really significant, and we know that that is always a legitimate reason to refer. And I think just to be aware that it is very much a non-site specific suspected cancer referral pathway, rather than I've got this patient, I haven't a clue what's going on, please investigate.
Fair enough. Okay, thank you very much for talking to
Thank
us
you.
today.